Thank you, Eric. Do you want to do a quick intro and then, or a quick startup, and then I can do introductions and turn it over to Dr. Hunt?
Absolutely. We'd like to thank everybody for attending the webinar today. If you could make sure you please include your first and last name, state of licensure, and your EMS license number in the chat that records your attendance for us. And in case we miss it in a different way, we have it there. If you have any questions during the webinar, please throw them in the Q&A or the chat, and we will answer them as we can. And additionally, if you are from out of state and need a certificate for attendance, please email me. My email will be in the chat for you to take care of that. And we're glad to start. So Dr. Scholl, it's all you.
Thank you very much, Eric. And thank you to all of you for participating in this webinar today. We're very excited to introduce Dr. Rebecca Hunt. Dr. Hunt is the medical director of Maine Health, Maine Medical Center, Portland's OB-GYN and MFM programs, meaning that she is very experienced OB-GYN physician who is in a leadership position in the hospital. More important, though, Dr. Hunt and I are long-standing acquaintances, and we're just catching up, as we sometimes do when we bump into each other. Dr. Hunt and I grew up together in the city of Portland and attended Deering High School together, where we were lab partners in chemistry and classmates in a lot of other classes. It is a pleasure to work with Dr. Hunt at this stage in life as well. And I think it's also always really fun when you bump into someone who you knew from a long way ago who still espouses the wonderful values that attracted you to them in the first place. Dr. Hunt, thank you for being here. And without further ado, I'm going to turn it over to her. We are excited to have you here and to share some of your expertise in OB emergencies. So thank you very much.
All right. Well, thanks so much, Matt. It is just really, it is great to still be in partnership and still be in Maine and to be serving the people of Maine. I will share my screen and in just a second. Oh, hang on. A slow poke. Here we go. Okay, can you all see this?
Not yet.
Not yet.
Oh, shucks. Let's see.
There we go.
Now. Okay, great. All right. So I'm going to talk about hypertension as in relation to OB emergencies today, as sort of, I think it's a growth area for all of us, and has been a focus in the state of Maine for the past year or so to try to help patients both in the hospital and out of the hospital get their blood pressure managed as soon as possible. So let me tell you some more about it. So I have no financial conflicts. I have a passion for OB emergencies and sort of share that love of crisis management and acute care that I think you all have. So I'd like to together imagine the scope of the problem, define current terminology, talk about recognition and management, and sort of talk about pregnancy and postpartum, initial blood pressure control, and describe seizure prophylaxis and management. So maternal hypertension is a growing problem in the U.S. People are older and sicker as they're getting pregnant as a population. And so therefore, we have greater risks for complications in pregnancy. And so all of the risks that are related to heart disease and hypertension are going up. And Maine is included in that. So I underlined here two of the most major causes of pregnancy-related deaths are cardiovascular disease and hypertensive disorders of pregnancy. That's HDP. I used a bunch of slides from the California Maternal Quality Care Collaborative, which some of you may have heard of. They are sort of the national leaders in improving maternal quality of care. And they give us a lot of great assistance with guidelines and free slides. So the spectrum of problem of hypertension in pregnancy, first we'll say there's some outdated terminology that many of us may have learned in school, including like severe pre-eclampsia, toxemia is like from the 70s, PIH or pregnancy-induced hypertension. We aren't using these terms anymore, and I'll tell you more in a minute about the terms that we do use. And on the right side of the slide, you'll see these are the conditions that we're talking about nowadays. So just super quickly, and it'll be nice to save this slide for your studies later, but chronic hypertension is blood pressure that's elevated outside of pregnancy or within the first 20 weeks. Gestational hypertension is new onset of elevated blood pressure. Preeclampsia is elevated blood pressure plus proteinuria or severe range blood pressures. And then people can have chronic hypertension with preeclampsia superimposed on top of that. The preeclampsia can have severe features, and that's related to lab abnormalities and certain symptoms like unrelenting headache and vision changes. HELP syndrome is a related problem in the preeclampsia spectrum that can be a severe life-threatening illness characterized by hemolysis, low platelets, and elevated liver enzymes. Eclampsia is a seizure related to hypertension, and then all of this can happen postpartum as well. And yeah, so like I said, it doesn't matter if a person is pregnant or postpartum. Hypertensive disorders can affect a person. The number one thing that we worry about is severe range blood pressures, and this is 160 or greater systolic or 110 or greater diastolic. And confirmed, so repeated in 15 minutes. And the word we want to get out to every provider and EMS person, whether a person works inside a hospital or out, is not to wait to treat this, which is a hypertensive emergency. And part of the reason we talk about this, especially with emergency providers, is that I know that this is not the range that you are all concerned with. So, if you have an older person and their blood pressure happens to be, 170 over 95, and that's just kind of where they live, or they just need some medication adjustments for a chronic condition, this is a different scenario. So, the reason for treating severe range blood pressure here is to prevent death due to stroke. And I don't know, the slide says the same thing about 4 times, so that's good. I'm sharing with you the algorithm that we use at the medical center in Portland. It's basically comes from the California Maternal Quality Collaborative, but we adjusted it to suit our needs here inpatient. Target range is somewhere 130 to 150, over 80 to 100. We aren't looking for perfection, but we are looking for below 160 over 110. And this algorithm talks about different medications that are depending on what you have available to you. If a person doesn't have an IV, nifedipine, oral nifedipine is appropriate. And talking about avoiding labetalol if there is asthma. And I'll go on to the next slide. So another one of the severe conditions besides stroke that we're trying to avoid is eclampsia, so a new onset of tonic-clonic, focal or multifocal seizures. in the absence of other causative conditions, so because of a hypertensive disorder. About 1 in 1,000 deliveries is affected by this, and mortality can be around 1% in the U.S., but can be as high as 15% in other parts of the world. And the most common prodromal symptoms that people complain of are headaches and visual disturbances. So these are two symptoms that really should be taken seriously. At the same time, up to 20% of women with eclampsia did not report any neurologic symptoms ahead of time. So we should all have a high index of suspicion. This is our algorithm for eclampsia, so seizure related to hypertension and pregnancy. Talking about the index of suspicion, about 26% of cases are in the postpartum period, so after 48 hours postpartum, but up to 6 weeks. So many times we think we're out of the water or we're safe. The placenta's out, the baby's out, and the pre-eclamptic condition usually should be recovering, but people are still at risk through 6 weeks. And up to 78% of people who have eclampsia had no prior hypertensive diagnosis, so can be a surprise. So thinking about hypertension in the emergency department, I alluded to this. So it's very important to identify whether the person has been pregnant in the past 6 weeks, and including now, and if yes, assess immediately and work towards treatment immediately. Additionally, on the right side of the slide, there's sort of the other cardiovascular symptoms that it's important for us to keep in mind as well, because of the cardiovascular disorders of pregnancy that can lead to severe morbidity or death. So ED clinicians and OB clinicians both should be aware immediately about such a patient so that treatment can be expedited. In terms, so I talked about our trigger blood pressure, 160, 110. That's our inflection point. I talked a little bit about some risk factors, signs and symptoms, and so it's important for any place to develop a workflow. How do you work between OB, EMS, OB, and ED? The OB service should always be called in, and maternal resuscitation should be prioritized. This I just have it in here as a reference tool for people who are interested later. Maternal early warning system. It's gives triggers for multiple severe conditions that can occur in pregnancy, so including sepsis, cardiovascular disease, and hemorrhage. But these are reasons to escalate care. So just there for your reference later. I won't read through it. Oh, and I talked really fast. Tell me if you have any questions or cases or things that you would like to talk about. And I will.
Dr. Hunt, thank you so much. Folks, any questions that you guys have in the about pregnancy-induced hypertension or any of the consequences of similar type events like eclampsia or seizures in pregnancy? If you have any questions, please use either the chat function or the Q&A function on Teams. And while we're going, Dr. Hunt, maybe I can get some questions aligned here with us.
Sure.
So I think one of the interesting things that we're noticing is across the U.S., management of hypertension EMS is not necessarily a standard practice. There's been, I think that's just been that's been because of the concerns for titration of medications, the importance of managing blood pressure very, very carefully, reducing the blood pressure very, very cognitively and very consciously, being
Yeah.
cautious about how much the blood pressure reduces. Although we are noticing a bit of a sea change in the pre-hospital world in that there's been more and more attention toward managing this type of hypertension.
Yeah.
And recently, the American College of OBGYN physicians and others, including the National Association of EMS physicians, have been thinking about pre-hospital protocols and guidelines, and included some guidelines around not just eclampsia and the management of seizures, but also pregnancy-induced hemorrhage, as well as pregnancy-induced hypertension. Um, in your experience, can you share with us can you walk through the algorithm that you guys use? You showed it, but could you walk through that algorithm with us and kind of touch base about a sequential and escalating practice, and how, in your experience, how well you've been able to manage blood pressure with any of the different medications on your list?
Mm. Yeah, that's a good question. So I would say our first line medication is generally labetalol, as it's uh, known to be safe in pregnancy and safe for the fetus, and for us, readily available. And so if there is an initial elevated reading, we then confirm it 15 minutes later. And if the blood pressure is still elevated to that severe range, then we immediately initiate, usually IV treatment. And so, but by far, the first thing I would do is give 20 milligrams of labetalol. 20 minutes later, 10 minutes later, repeat the blood pressure. And if still severe range, then go up to 40 milligrams. And so this, I don't know if these doses seem like a lot to you or not, but it does seem like somewhat frequently we have to go 20, 40, 80. And then if we've given that to do 140 milligrams total, then we will switch over to hydralazine usually. If a person doesn't have IV access, then we start with 10 milligrams of nifedipine PO. In the hospital setting, we have the benefit of having anesthesia or other people on hand who could intubate a patient if they have like a severe asthmatic response or something like that. But I would say that in my experience, some people don't seem to be very responsive to labetalol. And so it's sometimes we'll see like that switch over into hydralazine is kind of the trick that people need. Or it's sort of in the later on management, we may be giving them 800 milligrams of labetalol every 8 hours, but then they need one or two other agents in addition.
Dr. Hunt, do you guys ever use magnesium in the management of hypertension in pregnancy?
Not for hypertension per se. Like, we recognize that it may have a slight benefit in terms of the blood pressure reading, but not as like a direct treatment. For a person with severe range blood pressure, we're sort of simultaneously ordering and starting the IV push medications to manage the blood pressure while we're getting a pump ready to initiate magnesium to prevent seizures.
Looking at the ACOG guideline that they published in concert with others, including NAMSP, they do list it as a fourth line agent, interestingly, in that
Wow.
guideline.
Yeah. Yeah. And, and the thing is we're going to use it anyway. And so it's going to be there, whether it's first or fourth. I'm seeing I was going to
Oh,
look at
perfect.
the chat there.
Yeah, absolutely.
If a seizure patient is not known to be or not obviously pregnant, would it be detrimental to treat with your standard Versed? I don't know the answer to that, but we do treat with up until recently, we've not had the availability of IM magnesium yet. And so we have given people like IV Ativan so I don't think it would be crazy to use Versed.
Yeah, so I think this is a great question from Caitlin, who Caitlin, you're sort of acknowledging that sometimes it can be difficult. Your patient can't provide you history, right? And if there's no one to obtain collateral history from in the context of a seizure, it would not be out of the question to start with typical pre-hospital treatments such as benzodiazepines. And as you are acknowledging, our preferential benzodiazepine in the main EMS protocols is midazolam or Versed. However, if there is any suspicion for pregnancy, including that 6-week period of time after pregnancy, including magnesium therapy is recommended because of the concern for eclampsia or both in the perinatal but also postnatal period of time.
So do you have the ability to use magnesium outside of the hospital?
Yes. And it's we've recently, in fact, for everyone on the line, you will so everyone on the line will recognize some changes that our EMS for Children coordinator Mark Minkler brought forward from the EMS for Children committee, from some of the members of that committee, championed by Dr. Rachel Williams, to really emphasize the utilization of magnesium in cases where we are concerned that the seizure might be in the context of pregnancy. And so the big change you guys will see this time around is the inclusion of intramuscular magnesium if IV access is not available, which mirrors a lot of our practices around midazolam as well. So, yeah. Speaking of Mr. Mark Minkler, he has a great question in there. Can you discuss the baseline vital sign changes in circulating blood volume that occur during pregnancy and what might be found by EMS and perhaps exacerbated by having to call 911 or use EMS? And then secondly, can you discuss if even minor trauma during pregnancy? Can you discuss minor trauma during pregnancy and whether choosing the correct destination for this patient are important?
Wow, that's a lot there. I would say in terms of vital sign changes, number one, in the first and second trimesters, people tend to have lower overall blood pressure compared to whatever their norm is or what it will be at the end of pregnancy. And then, so many people with chronic hypertension, for instance, will not have elevated readings until way further along in pregnancy, so third trimester. And then heart rate tends to be a little bit elevated compared to non-pregnant states. So a normal heart rate would be something more like 90 to 105 rather than lower than that. So I wouldn't get too freaked out about a slightly elevated heart rate. In terms, some people do often sort of worry that like a blood pressure reading is like false because somebody's in pain or stressed out. And one of the things that we're sort of talking about nationally is that the brain doesn't care why the blood pressure is elevated. So if it's elevated 160 over 110 and sustained, even if it's in the context of pain or anxiety or fear or whatever, it's still worth treating. So we really encourage people not to sort of like blow it off or try to explain it away. In terms of minor trauma, choosing a correct destination, oh gosh.
Do you want me to tee this up a little bit?
Sure, yeah.
So I think this is an interesting question in light of the evolution of OB services in the state of Maine. And I think the
Oh,
background here
yeah.
is that we all, that even minor trauma in pregnant women with viable pregnancies can have significant impacts on the fetus. And in those situations, it is standard of care to observe, to evaluate the mother for significant trauma and treat the mother, but then to observe the mother and fetus for a period of time using monitoring systems. And so I think the question really boils down to, does the receiving facility have the ability to manage the trauma, the mother who suffered trauma, and B, does the receiving facility have the opportunity to, or the ability to monitor the fetus for a period of time? And
Yeah.
yeah, so I'll stop there
Okay.
and let you take over. How's
Okay.
that?
That's helpful. Thank you. I would say that sort of mirroring our in-institution sort of OB and trauma guideline. Anything above 20 weeks-ish probably should just go to a birthing hospital, and because below 20 weeks, that is not viable, and really the focus would be saving the mother. By and large, saving the pregnant patient is the way to save the fetus. And so it's good to focus on the person standing in front of you or lying down, as it were. But yeah, like you would want to bring the person to a place where a delivery could be accomplished if that was necessary.
Awesome. And I think, as we think about this, the age of the infant also is, or the age of the fetus is also a consideration, would it not be, Dr. Hunt? Because
Yeah.
the exceedingly young child will need NICU care, and if it's
Yes.
possible that entering into a system that has NICU care available right away is preferential, but if
Would
not,
be.
that child could
Yeah.
be initially birthed, resuscitated, and then transported to a NICU in the state or out of the state,
Yes.
depending on where you're at.
Yeah.
So,
Yeah. So, we do have a mechanism to have NICU come to birthing hospitals that are not Maine Medical Center and go get the baby and bring it back to our NICU setting. But yeah, so, it certainly is always a judgment call. I think a phone call to maternal fetal medicine can sometimes help provide some guidance, potentially. And if there is an awareness of like, oh, right, here's a hospital that only goes down to 36 weeks, but then 2 blocks away is a hospital that goes down to 24 weeks, that may help you make a decision.
yeah, and the other for immediate consultation for EMS clinicians, maternal fetal medicine may not be immediately available, but online medical consultation always is,
Okay.
and the physicians on the other end of the online medical consult call can certainly give advice in that regard as well. And if they do have questions, can link for you to MFM or OB physicians locally to help with that decision making as well.
Mm-hmm. Oh, great.
We have a really interesting question from Caitlin, who asks, do we need to be concerned about pre-eclampsia and eclampsia postpartum if the patient had a miscarriage? And if yes, how many weeks? What are your thoughts about that?
Gosh, yeah, Caitlin, you're asking some good questions here. I would say that if it is, if it was less than 24 weeks, no. But if it was over 24 weeks, then yes, as a general rule. And I know normal people don't think of pregnancies in weeks, but I really encourage everyone to encourage your friends and family not to say not to think about it in terms of months, because it's difficult clinically. In terms of metoprolol, 5 milligrams over 5 minutes appropriate. I don't know. What do you think, Matt?
Well, so that's a great question, and I do want to acknowledge that we don't necessarily have a protocol for this in main EMS's protocols at this point in time. It is really Dr. Hunt is sharing with us some very cutting edge national thoughts about this, and we see that reflected also in this joint American College of OBGYNs and NEMSP work that's being done. Now I also want to recognize that our protocols are in constant evolution. And while you will not see this in the 2025 guidelines, protocols, as those guidelines came out just a little while ago, it is possible that things could change in the subsequent protocols. So what I would offer you, and I think it was let's see, Nick who asked about metoprolol 5 milligrams. So the answer is it depends. And I think that's the most appropriate answer for many of the things in medicine. It depends on a lot of things. It depends on the highest blood pressure. It would depend on the patient's symptoms. And I think it would depend a little bit on the other nuances of the case, including your transport time to the hospital that you're transporting to. All of those things would weigh into the decision making that would come with the answer to that question for the patient in front of you. And because it's a little bit of a nuanced question, I think the most appropriate approach at this point in time is to reach out to online medical consultation and have a conversation and include those things in your discussion.
Yeah.
All of those would be important to the decision making. That would be very, very helpful to give the right answer for the right patient at the right time when you're caring for them. But keep those in mind. Think about what the patient's clinical symptoms are. Are they having a really bad headache? Are they having blurred vision? Are they having any pain anywhere, including abdominal pain, which I think is important for us to acknowledge. We want to do a really good examination, including the person's neurologic status, and then trend their blood pressure a couple times to get an idea of what's happening. Is that blood pressure durable and persistent over time or not? And then dialoguing with online medical control will be the next step. As Dr. Hunt mentioned in the chat, the foundational treatment of that supports the pregnancy is treatment of the mother. And so our therapies in the field can avoid some of the downstream consequences, and it's important to coordinate that with the receiving hospital. So a little bit of a nuanced answer to your question, Nick, but I hope that answers it. And Dr. Hunt, if you have anything else to add that
I would just say
EMS
that
physician would benefit from, please.
Oh God. I do think it's this is a really exciting area, for development, is to come up with what is the appropriate, I love adapting the CMQCC guideline for use at Maine Medical Center. What are our local resources? So I think it's really exciting to think about doing a similar thing for the out of hospital environment. So what are your resources, and what does make sense? So I think we should work on that.
Do you know off the top of your head what metoprolol is rated from a pregnancy standpoint?
I don't, but long-term high dose use would reduce fetal growth, but in an emergency setting, I would not be concerned about it. And people do take metoprolol for arrhythmias during pregnancy, so it's not a particularly worrisome med. I would say you would just want to be sure not to overshoot. Since I have less experience with it, I would not want to overshoot and get to too low of a blood pressure.
Eric, you have some questions in the Q&A. You want to take over for a sec?
Yeah, we do have a couple that popped up earlier in the presentation. One of the questions that was posed was, why are patients still at risk after 6 weeks, which I believe is probably referring to that gestation, after the birth period.
Why? Well, why? I don't know why, It just is, it's a fact of the disease. And they don't really truly understand preeclampsia and what exactly is the cause, and what exactly is the solution, and maybe some immunological process that relates to the placenta. But yeah, it sort of is, can be come at disturbingly late periods of time, and you're like, well, gosh, she delivered 4 weeks ago. Why is this happening now? But it does.
Is there any pattern or anything, any like telltales that are sort of say if a person's going to go longer, like have a potential chance that no indicators or anything?
Not really. I mean, I think it's just basically, because like up to 78% of people never had hypertension before an eclamptic seizure postpartum. I would say just like having a high index of suspicion for all people who are pregnant or have recently had a baby, because it really can happen to anybody.
And from our friends at the South Portland Fire Department, what can we do non-medication wise to potentially lower BP in a pregnant patient?
Well, certainly have them lie down with a leftward tilt, so like a towel or blanket roll under their right flank, to get them off the IVC. Darkened lights, quiet environment. Those would be the things I would do first.
Thank you.
Everything else in the question and answer?
That's what I have in the Q&A.
We've had another question pop up in the chat. It reads, are there any critical scenarios with substance abuse during pregnancy or postpartum? That is a short but large question.
Yeah. Yes.
Do you want to?
Yeah, I would say that for people who are using cocaine or amphetamines or crystal meth, like hypertension is a concern, as well as abruption, so tearing of the placenta or separation of the placenta. So if people are using substances, I would be looking at their blood pressure. Also, if they're withdrawing, would be another time. And I would treat those blood pressures if they're elevated. Again, no matter the reason, it's good not to be severe range.
And I think it's also fair to say that even with other substances, there's always a risk to the fetus. There's a risk to the mother, therefore the risk to the fetus. There's also a direct risk to the fetus. And that raises some very challenging ethical considerations that undoubtedly you've had to deal with.
Oh yes,
probably much more than we've even been aware of. I do know there are a couple shared cases that we've had conversations around regarding a couple of patients in those circumstances, and those can be very challenging to make decisions about at the point of care, because a lot of those challenging ethical considerations have a lot of nuance to the answers, and all of the hospitals are here for EMS clinicians when those questions come up, and the best way to access support and help for those is to link to online medical consultation to problem solve through those. And there are lots of examples where Dr. Hunt and her group, as well as our ethicists and others, have all weighed in and tried to assist in the decision making around those very, very challenging circumstances.
Yeah, absolutely. And it's you got to work with the human being and where they're at, and you often have to bring in multiple teams to help kind of take care of all the perspectives. In terms of public health programs, I think that what public health programs exist to educate patients about eclampsia, preeclampsia, emergencies. We don't want to scare people. Absolutely. So, number one, at the time of discharge, I can't promise for every other hospital, but I feel like I can make a pretty good assumption. Patients are given both written and verbal discharge instructions with post-birth warning signs. And so those include signs of severe postpartum depression and anxiety, hypertensive disorders, sepsis, and hemorrhage, and are strongly encouraged to share those with their family members and to call for help if any of these warning signs come up. So that exists definitely at the point of in-hospital care. Our postpartum unit recently started a program where postpartum patients are being given an orange bracelet at the time of discharge to wear. And oh, that's great. Yeah. Oh, thanks, Emily. Yeah. And so these orange bracelets, say something like, I'm postpartum. And it's really for you all. It's for EMS and emergency providers to help sort of easily visually identify that a patient is peripartum. And Emily Watson wrote into the chat. She is one half of the state's perinatal outreach program. And she wrote that public health nursing specializes in maternal child health and is well trained and in those post-birth warning signs. And they can see patients in their homes up to a year.
I imagine, Dr. Hunt, that a lot of the, I'm not aware of the public health discussions and dialogues and education for patients, but I imagine that there's a lot of one-on-one education that occurs during initial OB evaluations and then during continuous OB evaluations. As we see changes in the system of care around obstetrics in the state and frankly, nationally, are you aware of any conversations that have been ongoing in an attempt to either expand services or to capture and reduce the incidence of unevaluated pregnant patients or under-evaluated pregnant patients?
I mean, I think it is a little bit difficult in the current climate. But one thing I can say is that Maine is the recipient of a grant, one of, I think, 14 states, called Transforming Maternal Health. And it's a 10-year grant. It's a substantial amount of money, but when you divide it over 10 years, it's like it becomes a fair amount less substantial. And this is a program that is being self-built by the state of Maine. And so that may be one area where that will be worked on. I also, there are sort of individual local little public health initiatives in terms of helping patients learn how to self-check their blood pressures and sending them home with a blood pressure monitor so that they can remotely basically monitor their blood pressure and connect with their clinicians rather than having them drive in to have appointments.
Well, Dr. Hunt, I know you do have a meeting coming up. Do you have time for one more question, or?
I do, yes. Would you like me to do that?
Yeah, if you don't mind.
Last one.
Clinical relationship between eclampsia and postpartum depression.
I don't know the answer to that, I have to admit, but I would like to look that up. Emily, if you know, please speak up. What I would say, though, is that patients who have complications in pregnancy, and especially if they lead to interventions, and especially if the interventions lead to trauma, I think it does leave patients vulnerable to the potential for peripartum mood disorders, which would include either anxiety or depression or both. So I don't know, but I would think so. One last thing that just popped up into my mind about sort of thinking about identifying people and sort of what are some of the issues like outside of the hospital or in the community is that I would say a significant number of new Mainers don't have different sort of health knowledge and health beliefs and don't necessarily recognize preeclampsia as a condition and don't necessarily believe in it. And so they may not recognize when they are at risk. And so, we have been talking to them over the course of weeks about their high blood pressures, their risk of seizure, this and that. And the patient themselves may or may not believe it or know it. And so they may not identify to you, hey, I have this risk factor. I could do one more tiny question.
I think Dr. Zimmerman has her hand up.
It's not a question. It reminded me, I did a cardiovascular disease in women lecture and recently for grand rounds for our residents, and women who have had hypertension in pregnancy, it does increase their overall cardiovascular disease risk.
Yes.
Later in life, and it's not a risk factor that we think about asking, but I want to put it out there because it's not appreciated by most medical providers.
Yeah.
Well, Dr. Hunt, thank you for all of the material today. You covered a lot of ground, and we really appreciate it. And we thank you, and we look forward to perhaps even talking to you further about topics such as hemorrhage or eclampsia in the future if you're up for it.
Super. I love hemorrhage. That's my favorite.
For participants, if any other questions arise, please reach out to us through Eric Wellman. We will do our best to answer your question. If we cannot answer your question ourselves, we will reach out to experts like Dr. Hunt and or her directly and see her input on it. We also want to thank you all for your participation today. Within the chat, Eric has made added notices of upcoming webinars. We have another webinar this week, as a matter of fact. Our trauma team is going to talk about hemorrhagic shock, TXA, and extremity trauma in the field. And then next month, our very own Dr. Kate Zimmerman is going to talk about spinal motion restriction and the evidence-based practice surrounding that. We invite you to consider participation in that webinar. Eric, any final word for the audience at all?
I'd like to thank everybody for coming to these. Like Matt said, tomorrow our trauma service is actually starting their first of many webinars that they'll be offering. So we'll, if you're available, we're here tomorrow at 1 again to see you. Thank you all for making these a great experience for all of us. And if you need anything, please reach out to us. I've put my name in the chat with my email address. You should also have all the webinar stuff, and the evaluation has been stuck in there somewhere. It's buried. If you could fill that out, that's greatly appreciated. The more you give us feedback, the better we can make these presentations for the future. And if you haven't heard, we're doing a conference on November 6th, 7th, and 8th here at the hospital with both virtual and physical attendance. There'll be that'll be opening up soon. Look forward to seeing you all there.
Thank you, everybody. Take care.